Good afternoon, everyone, and welcome to another Facebook Live Lunch and Learn with the Center for African American Health. We hope that everyone who wanted to be tested for COVID-19 was able to visit our drive-through testing site today at the Center for African American Health. We still got a few more moments if you want to hop in that car and just drive right on down to 3350 Hudson Street, right here in Denver. If you are unable to attend the drive-through site, please sign up to receive our weekly e-blast by visiting caahealth.org to ensure that you are immediately notified of the next opportunity. Before we officially begin, and while we wait for a few more people to join, I'd like to introduce myself and tell you a little bit more about the Center for African American Health. I am Yolanda Gotier, and I am the Senior Living Health and Wellness Coordinator. And essentially what that long term means is that if you are 50 years plus, we're going to teach you how to live your life like it's golden. We're going to make sure that you're doing it and creating a healthy journey of wellness, fun, laughter, and joy. For those of you who may be unfamiliar with the work of the Center for African American Health, we've been in the community for more than 20 years with a focus and a strong commitment to improving the health and well-being of the African American community. We do this through community-based, evidence-based disease prevention and disease management programs, events, and services. You can learn more about our work and our programs by visiting our website at caahealth.org. As we move through today's session, please feel free to type your questions in the chat box, and we will address them if time permits. You know what? In the blink of an eye, we are nearing the end of 2020. We are already well into the month of October, which is nationally recognized as Breast Cancer Awareness Month. I want to start off by sharing some general information to frame our discussion today. According to the American Cancer Society, the median age of breast cancer diagnosis is between 2012 and 2016 was 62. That's pretty young out there. This means that half of women who develop breast cancer were 62 years of age or younger at the time of diagnosis. The median age of diagnosis was slightly younger for Black women, and that was at 60, with white women at 63 years old. And that source comes directly from the American Cancer Society Breast Cancer Facts and Figures 2019 to 2020. So today, during our Lunch and Learn session, we hope to provide you with valuable information because we know that knowledge and early detection saves lives. Joining me today is Dr. Jerome Schroeder, the Director of Imaging at the Breast Care Center in SCL Health, St. Joseph Hospital. Welcome, Dr. Schroeder.
Thank you, Yolanda, for having me here. Can you hear me okay?
I can. So we know that you're busy, and so I'm going to dive right in with questions. And before we do that, would you just share a little bit of your background so that we can provide this information for our viewers?
Sure. I was originally born in St. Louis, Missouri, and when I was a teenager, moved to rural Illinois to kind of move back to the family farm area, and then went to medical school at the University of Missouri, rather, in Kansas City, right out of high school, and then moved on to my residency out in Philadelphia for 5 years. After I finished that, I paid back the military because they helped me through medical school. I did that for a little over 3 years in New Mexico before taking my first real job in California. In 2002, I came to Denver to do a fellowship in breast imaging so that I could focus just on breast imaging and breast cancer diagnosis. And I've been here ever since. I initially worked for Kaiser for 5 years when I got out of my fellowship, and then joined my current employer in 2008, which is Diversified Radiology, which is one of the big radiology groups around town. I could move around to different areas that we cover, but I was hired kind of to help develop the breast care center program at St. Joe's when I was hired in 2008. So St. Joe's is my home clinic. I'm the main breast radiologist here, and I'm here the vast majority of the time.
Okay, well, thank you for that. Now, I'm jumping right into the questions. It seems like there's conflicting information concerning recommendations for women regarding the necessity of mammograms and when that screening process should start. Please tell us why mammograms are important and when women should be getting screened.
Well, that is the most loaded question when it comes to breast cancer detection and screening, because it is very confusing. I'll take it back a little bit in time. We didn't start doing regular screening mammograms until the late 80s and early 90s. For about 20 years from that point on, it was generally recommended that all women from age 40 on should get a mammogram every 1 or 2 years. Then in about 2009, there was a kind of a curveball announcement by the United States Preventative Services Task Force. I'll just refer to them as the task force. They came out with revised recommendations in 2009, and they stopped routinely recommending mammograms for women in their 40s, and instead said that women should start at age 50 and go every other year. Well, that landed like a lead balloon around the medical community, and they were widely criticized for their recommendations. I could get into their specific errors and how they reason, but that's probably a topic for a different talk. But suffice it to say that a lot of people came out against those recommendations. And about 3 or 4 years ago, they revised their recommendations only minimally. They still recommended only every other year from 50 on, but they sort of softened their previous recommendations and said that women in their 40s could get mammograms if they wanted to, or if their personal history directed them to do so. That still was very confusing because many medical organizations, including the one that I'm a member of, which is the American College of Radiology, have always recommended annual screens for all women from age 40 on, and we still do. And many other organizations like the American College of Surgeons and American College of OBGYN doctors all still recommend annual screening mammograms. Then, to sort of make it even more confusing, the American Cancer Society 3 or 4 years ago came out and said that you should start at age 45. So now we have 3 overall recommendations: annual from 40, annually or every other year from 45, and annually or every other year from age 50. And it's just not been a very good service to women. Fortunately, women are smarter than their experts, because since 2009, when those recommendations changed, women have still been getting their mammograms fairly regularly. There's been a little bit of a dip, but overall, most women realize and understand the importance of getting mammograms and understand the importance of getting them in their 40s. And here's the reason why. Breast cancer starts to occur in some women as young as their 20s, but obviously it doesn't occur that often, so you would never screen everybody in their 20s. We know from just epidemiology, just looking at when breast cancers occur, that they start to accelerate in the 40s, and they really start to take off in the mid-40s. So the task force recommendations, I think, are absolutely wrong. In fact, I think they're dangerous if people actually follow them, because we know that breast cancer accelerates in the 40s. Then you think, well, when should I start? Early 40s or mid-40s? For the whole population, the acceleration really takes off at age 45 around. But for African-American women, actually, the acceleration occurs earlier. So in Black women, they start to see the acceleration in the early 40s. So I'm sort of a proponent of the KISS kind of approach, keep it simple, stupid, because I like to keep things simple to where I understand them, and so that I can convey that information easily to other people. And so, yeah, you have all these recommendations, but the science says that the best approach for the entire population, no matter what your race, no matter what your background is is to start screening mammograms annually from age 40 on. Now, here's an interesting thing. About the same time that the task force was changing their recommendations in 2009, the Obama administration was passing the Affordable Care Act. And the interesting thing about this is, as everybody probably knows, the Affordable Care Act requires coverage of many screening tests at no cost to patients. So whether it's cervical cancer or diabetes, things like that, there's a lot of tests that everybody who's covered with insurance is allowed to have without any out-of-pocket expense. They tied virtually all of those tests to the task force recommendations in those various areas. The task force gives recommendations for all different aspects of medical care. So the Affordable Care Act tied their coverage to the task force recommendations for many screening tests, except for mammography. Because the task force had come out with these change recommendations, there's actually an amendment rather to the Affordable Care Act that requires full coverage at no cost to any patient for annual screening mammograms from 40 on. So Obamacare, or the Affordable Care Act, actually recognized that the task force recommendations for breast cancer screening were wrong and misguided. So they created a carve out for that particular screen. So if you are covered by insurance, with very few exceptions, you must be allowed to get a screening mammogram every year from age 40 on.
Okay, well, thank you for that. Let's see, how often, I know you've already alluded to this, but really, how often should women get screened, and what should they be looking for when performing self-exams at home once a month?
That's a very good question, and I did kind of allude to it before. We highly recommend annual screens, that's once a year, for all women from age 40 on, and here's the main reason why. There's one of my mentors travels around the world and gives talks about breast cancer to all types of audiences, and he came up with this concept of a sojourn time. So sojourn, as we all know, means journey, and there is a journey that a cancer takes when it starts to form in the breast. The first part of that journey, nobody can see it because it's too small and nobody can feel it. The second part of that journey, it starts to become visible on screening mammography. And then the third part of that journey is where it gets big enough to where it can be felt. So you can measure the time that it takes between when it first shows up on a mammogram to when it starts to be clinically evident, a mass that the patient or the doctor can feel. That's a measurement, and that's usually measured in years. The sojourn time for breast cancers in women under 50 is just over 2 years. So you only have about a 2-year window to go from a screen-detected cancer to a clinically evident cancer. So if you're only screening every other year, there's a good chance you're going to miss the opportunity to find that cancer in what we call preclinical stage, which is when it can be seen on a mammogram but not yet felt. So I created a concept of screen drift because I look at mammograms all day long, and very few women get their mammogram exactly 12 months from their previous one. And we all know life gets in the way for dental recommendations and eye exams and all that stuff. So you drift away from when you're supposed to get your screen. So my point is that if you screen every year, even if you drift out a couple of months, we're still under that 2-year sort of window to find the cancer before it can be felt. If you recommend going every other year and then you drift out beyond 24 months, then there's a good chance that if you develop a cancer, you're going to feel it first before you get that next mammogram. And the importance of that is the whole thing about surviving a breast cancer depends on 3 main things. One is the size of the cancer. One is whether or not it has spread to the lymph nodes under the arm. And one is how aggressive it looks under the microscope. When I give presentations, I have a slide that has a picture of an M&M next to a plum. And even though M&Ms aren't good for you to eat every day, when it comes to breast cancers, that's the size you want. You want the size of an M&M or smaller. When I read screening mammograms, I see M&M-sized cancers all the time, before the patient even knows they have it and before it's causing any symptoms. If I find that cancer at the size of an M&M, that patient survives more than 98% of the time. However, if she's not getting a mammogram or her doctor didn't tell her to get a mammogram and that cancer becomes palpable to where she can feel it or her doctor can feel it, then that cancer on average is about the size of a plum. And that's much bigger than an M&M, obviously. And when you have a bigger cancer, it's more likely to have spread to the lymph nodes. So the difference between a screen-detected cancer survival and a clinically detected cancer, so the difference between that M&M and that plum is from a 98% chance survival or greater with the M&M to a 75% chance of survival at the most if it's the size of a plum. So again, keeping it simple, annual screening mammograms for all women from 40 on gives every woman the best chance to survive a cancer should she develop it. And that's really what we should be offering everybody so that they have the opportunity to survive a cancer if they develop it. And to get back to one of your previous questions, breast cancer occurs more frequently in white women, although I just looked it up today, and the gap is narrowing. So the incidence between African American women and white women is narrowing. So at some point in the future, probably the incidence will be about the same. As I mentioned earlier, however, breast cancer occurs more frequently or starts to accelerate more quickly in African American women in their very early 40s compared to white women, which accelerates more in their mid 40s. The other thing of difference is that for whatever reason, I don't think we know this. We know it's genetic, but we don't know exactly what the genetic tie is. African American women are more likely to get more aggressive cancers, what we call triple negative cancer. So for all of those reasons, if you are a non-white woman, even though your overall risk for cancer may be a little bit lower than white women, it is more important for non-white women to screen every single year from age 40 on.
Okay, thank you for that. What are some of the associated risk factors that are associated with breast cancer?
It's a very good question too. We don't know how to prevent breast cancer. We can minimize people's chances of getting it. You can divide your risk factors into two broad categories: those that you cannot do anything about and those that you can do something about. What I mean by that is the two biggest risk factors for getting breast cancer are being female and getting older every day. Obviously, you can't change either of those two things. Other things that you cannot change are your genetics. You can't change your race or your ethnicity. You also can't change when you started having menstrual cycles. If you started early in life, that is a risk for breast cancer. You also can't control when you stop having menstrual cycles or when you go through menopause. If you go through menopause late, that's a risk factor for breast cancer. And the reason is, the more years that you have menstrual cycles, the more your breasts are exposed to estrogen. And estrogen, from a hormonal standpoint, is the biggest culprit over time in forming breast cancer. That's why the vast majority of breast cancers occur in women as opposed to men, for instance. But if you have more menstrual cycles uninterrupted, so you could start menstrual cycles early or menopause late, you're at a higher risk. So those are things you cannot change. You don't have any control over. What you do have control over are some things that, again, none of these things will prevent a breast cancer, but you can increase or decrease your chance. So lifestyle choices like alcohol consumption, even having just an average of 1 or 2 drinks a day can increase your risk for breast cancer fairly significantly, so you want to minimize that. Having a normal body mass index, if you are overweight or obese, that is a risk. Why is that? Well, estrogen is fat soluble. So the more fat cells or the larger fat cells you have in your body, the more you can store estrogen. That means that even if you stop having menstrual cycles, you still have quite a bit of estrogen in your body, and that slowly makes its way back into your bloodstream and starts to have its effect on your breast tissue. So the closer to an ideal body weight that you can get, the better. Like anything else with good health, if you have a sedentary lifestyle, if you don't exercise, if you don't eat very well, those are risks for breast cancer that you do have control over. If you never have children, or if you have children after the age of 30, that is a risk. Again, why is that? If you have children early in life, you interrupt that estrogen, that uninterrupted estrogen cycle from having just regular menstrual cycles. So if you have a child early in life, that's actually protective. And then there's a little bit of evidence that shows that if you breastfeed, at least for a year, that's somewhat protective against breast cancer.
Okay, thank you. So now I want to discuss a few of the common misconceptions you often hear regarding breast cancer. And of course, we're going to start with mammograms. Is it true that the compression from the mammogram causes breast cancer, or that the radiation from the machine poses a risk?
So the answer to the first question is absolutely no. Compression of the breast does not cause any adverse effects or lasting adverse effects to the breast tissue. It can be uncomfortable, however, to get a mammogram, but if you go during the right time of your menstrual cycle, and if you go to a highly specialized clinic that has highly trained technologists to do your exam, the amount of discomfort from getting a mammogram can be minimized. In other words, if your breasts are sore during a certain time of the month, don't get your mammogram during that time of the month. Wait till your breasts feel better. If they're always kind of sore, pop a Motrin or a Tylenol 30 minutes before your mammogram. That can definitely help. The difference between going to a general radiology department and a breast-specific clinic is that the technologists are just much more used to dealing with all types of patients in a breast center. One thing that you can do to make your mammogram experience more comfortable, and this is not what you want to do maybe in life, but it is good to do in a mammo clinic, and that is to slump your shoulders. One of the biggest reasons why people have discomfort when they get a mammogram is that they tense their chest muscles, which are behind your breast. And if you tense your breast muscles and you're sort of pulling back against the technologist, and then everything's uncomfortable. If you slump your shoulders forward, that relaxes your chest muscles, allows the breast tissue to be properly positioned, and you get a better mammogram overall, but you also have a more comfortable one. And then in terms of the radiation, that's probably one of the most common fears that women have, and one of the most common reasons why women say they won't get a mammogram is because they fear the radiation. The fact of the matter is, mammography is one of the lowest dose of radiation that you can get from any imaging study. There's only a couple of imaging tests that have less radiation than a mammogram. And you can think of it sort of in general terms. The amount of radiation that your breasts receive with a standard mammogram, that's 2 images of each breast, is about the same amount of radiation that we all get just from background cosmic radiation, just walking around doing our thing over about 7 weeks. So I am a lumper as well as the keep it simple. And so I just lump that into about 2 months of background radiation. In comparison, if you ever had a CAT scan, which also uses x-rays, but it's a more specialized form of x-rays, of your entire body, that is equivalent to 5 years of background radiation. And sometimes people, when they get a CAT scan, they get it twice, once before and once after contrast is injected into the veins. That's a very common test. And if you have one of those, then you've just gotten 10 years of background exposure of radiation. And basically, you can sum it up as a CAT scan is basically a lifetime's worth of radiation from mammograms. So you can get 1 CAT scan or 30 mammograms, and that's about the same amount of radiation. So radiation should not be the reason you don't get a mammogram. Another way to think of it is if you fly cross country in an airplane at about 30,000 feet, say from LA to New York, you just got a mammogram's worth of radiation because you're that much closer to the sun. So if that caused cancer, then we would see a lot of breast cancers in flight attendants and pilots, and we just don't. So radiation we need to think about it, and we minimize it as much as we can, but it's not an overwhelming factor, and the benefits far outweigh the risks.
Okay, thank you. Many women are scared to get screened because they fear the diagnosis. So what does it mean when you go in for your mammogram and they read it, and then they say, oh, you need to come back in because we want to put some markers in your breast? What does that really mean?
So there's a lot of different sort of scenarios. Generally speaking, most people that get a screening mammogram are never going to be called back. So if I read 1,000 screening mammograms, and a screen means that you have no symptoms. So symptomatic mammograms, different story. But for the vast majority of people, you're just going to go in for a non-symptomatic screening exam. Out of 1,000 screening mammograms, I'm only going to find 3 to 5 breast cancers. So it's only like 1 breast cancer per every 200 screens. So the vast majority of women are not going to get called back ever in their life. Say they get 30 or 40 mammograms throughout their life, they'll probably never get called back. Many women will get called back once or twice. at most about 10% of people get called back. So if there's 100 screens, maybe 10 and even fewer, it should be fewer really, but we'll just say 10 women will get called back. Out of those 10 women, maybe 1 or 2 will have a biopsy. And as I mentioned, you have to do about 3 or 4 biopsies to get 1 cancer. So the little markers that we place depends on what the procedure is. Most of the time when you have a biopsy, we place a tiny little metal marker. It's usually either surgical grade steel or titanium, just like we would use for other medical procedures, and very sterile. It's about 2 millimeters in size, about the size of a gnat. But it's very visible on a mammogram, and some of them are very visible on ultrasound. So when we do a biopsy, we mark that spot for future reference. Now, most biopsies are not cancerous. So if it's not cancerous, nothing more needs to be done. That little marker stays in your breast forever. The purpose of it in that case is for your next year when you come back, there may be a part of that original biopsy target still visible on the mammogram, but that reader of that mammogram will see that little marker next to the target or what's left of it, and they'll know that it's already been addressed and you won't get called back again. So one of the purposes of the marker is to prevent you from getting the same thing called back year after year after you've had a biopsy. The other purpose of the marker is if it is a cancer, and sometimes we get a result that's not cancerous but still needs to be surgically removed, that little marker guides the surgeon where to take out tissue. Without that marker, the surgeon would probably have to take out a lot more tissue with a lot less optimal outcome in terms of the appearance. So those little markers are very safe. I think in my career, I probably put in thousands and thousands and thousands of them. And one time, a woman was convinced that it was causing her discomfort, and so we took it out. I don't know if it really caused her discomfort, but that's the only time I've really had to remove one because of a patient complaint. Most women have no idea that it's there. Once it's there, they never feel it. It does not show up on airport alarms or metal detectors.
Okay. Does a family history of breast cancer put someone at a higher risk?
It does, and I can't tell you exactly how it does. There are calculators that add your family history and other personal characteristics that give you a percentage risk. So kind of talking in broad terms, the average risk person overall, without knowing anything else about you, has about a 11 to 12% chance of getting breast cancer in her lifetime. So in the nation, that's 1 in 8. And in certain parts of the country, it's a little more common than that, but about 1 in 8 women will get breast cancer in their lifetime, and that translates into about a 12 or 13% lifetime risk, or 12 to 13% lifetime risk. So that's the average risk. Through these calculations, which include family history, if your calculated risk is 20% or higher, then you're considered high risk. We have different recommendations, more aggressive screening perhaps for women in that high risk category. And then there's that middle category between, say, 12% and 20%. That's sort of a gray zone. We don't have great recommendations for women or who fall in that middle zone. So if you have no personal history of anything yourself, but say you have a grandmother and an aunt who had breast cancer and you don't have very many women in your family, that probably raises your risk above average, but not up to the level of high risk. But no matter what your risk is, if your average risk, annual screens from 40 on. If you're high risk, we usually add an additional test once a year. In between that usually should be a conversation between you and your radiologist. Yes, we actually talk to patients, or you and your primary care doctor if they're comfortable having that conversation. If they're not, there's a lot of breast surgeons that take care of a lot of patients that don't have breast cancer, but they have other risk factors, and those surgeons sort of treat them along the way and make recommendations depending on the person's personal situation.
Okay, so we have a question from one of our viewers, and it is, what do you think about checking to see if a woman has the BRCA gene?
Okay, so BRCA gene, BRCA just stands for breast cancer, it's just abbreviated. There's a BRCA gene 1 and there's a BRCA gene 2 out there. So there's 2 different genes. These were the first genes that are identified that put you at a higher risk for breast cancer. And in those cases, very high risk, upwards of 80% chance of getting breast cancer if you have one of those genes. So if you do have the gene, then we make very specific high-risk recommendations. We usually do more aggressive screening. Some women will go on some medications that's almost like chemo to prevent the formation of a cancer. And a lot of women, if you do have that gene, at some point you're recommended to have your breast and your ovaries removed to prevent cancers from forming, because these genes also increase your risk significantly for ovarian cancer. So Angelina Jolie, for instance, she had that gene. She had her breast and her ovaries removed, obviously after she had children. And a lot of women will do that. They'll know they have the gene at a younger age, maybe even their 20s, but if they plan on having children, they'll sort of wait until they're done with that, and then they'll have the prophylactic surgery. But if you're at average, if you don't have any family history of breast cancer, then you definitely do not need to be tested for the gene. If you have a couple of distant relatives and you have a lot of women in your family, you probably don't need to be tested for the gene. If you have multiple cases of breast cancer on either side of your family in women who are under the age of 50 or premenopausal, then there may be a genetic reason for those cancers. So what we recommend is that even if you're not sure, but if you do have a lot of breast cancer in your family or you're just not sure, talk to a genetic counselor. We always recommend doing the counseling along with the testing, because any doctor or any clinic can run a test, but they may not be equipped to deal with the answers of that test. Even if you're negative, there may be counseling that will help you make better choices about your breast health. So most breast centers have a high-risk clinic, or they have a genetic counselor. We certainly do on our staff. So I would recommend that you talk with a genetic counselor first, get counseled before doing the test, and then if it's appropriate to have the test, get the test. It's just a simple cheek swab, a very easy test, and then return to that genetic counselor after the results are in to be counseled as to what those results mean.
Okay. I heard you mention earlier that men do develop breast cancer. Are there any similarities, any major differences between men and women who develop breast cancer?
So yes and no, kind of tongue in cheek. The main difference is men ignore their bodies. So usually when they come in with the cancer, it's a lot further along than a woman. And I don't mean to make light of that. Men should certainly be aware of any changes in their body, just like women. But how it presents is identical to breast cancer in a woman. We can do mammograms on male tissue. All men have a little bit of breast tissue because all humans are female as in the womb until testosterone makes them into male. So that's why men have nipples, that's why men have a little bit of breast tissue, and that's why men can develop breast cancer. It's very limited, only about 1% of breast cancers occur in men. But to put that into numbers, and these numbers have gone up every single year since I've been doing this, and I've been doing this for over 20 years. And I just checked again today, it's estimated in the United States that there's going to be about 275,000 new cases of invasive breast cancer in women, with another 50,000 of what we call pre-invasive cancer or non-invasive. It's still cancer, but it just hasn't broken out of the milk ducts yet. So that's a total of 325,000 new cases of breast cancer each year in women in this country, and that's just this country. Men have about 2,700 cases. So it's actually less than 1%, a little less than 1%. But it behaves just like female cancer. It's detected and treated just like female cancer. The main difference, though, is men cannot produce milk. So there's two main types of breast cancer. One, the vast majority occurs in the milk duct. So it's ductal cancer. And when men get cancer, it is almost always a ductal cancer. About 15% of the time in women, the cancer can start in the milk lobules, which is where milk is produced. Milk is produced in the milk lobule. It's conveyed to the nipple through the ducts. Most breast cancers are in the ducts in women. Virtually all breast cancer is in ducts in men, but a certain percentage of cancer can be in the lobules in women.
All right, thank you. So, Dr. Schroeder, we are really out of time, and we had so many more questions for you. So I want to make sure that people have information, and I am going to share the link to your website. So for those of you with more questions, and And according to Dr. Schroeder, they will be able to provide you with some information and some answers. We encourage you to visit sclhealth.org. And this link has also been provided in our chat. SCL Health also offers a mobile mammogram option, and CAA Health plans to partner with them as soon as the schedule permits us to do so. Can you tell our viewers what's involved in this process as we wrap up and what they need to know regarding COVID-19 related precautionary measures?
That's a good question, and I think that we're taking the same precautions as most clinics that have reopened after the initial lockdown. So we limit the number of people that can be in the clinic. You have to be spaced apart, of course, if you're in the waiting room, but our main goal is to make there not very many or no people in the waiting room, so we space out the appointments appropriately. The equipment in each exam room is wiped down between every single patient. Masks are required. Your temperature is taken as you enter the building, and certainly if you have symptoms, we ask you not to show up. So, and I believe when you make the appointment, the questions are asked, and then I think with a reminder call before your appointment, the questions are asked if you have symptoms, and then of course when you arrive at the building, you're asked again about symptoms. So far as I know, none of the providers in my building have been infected, and as far as I know, no patients have been infected after visiting our clinic.
Thank you. We're definitely out of time, and so this video, along with other information, will be on the center's website at caahealth.org. Don't forget that you can also go to sclhealth.org for additional information. We want to thank you, Dr. Schroeder, for all of this information, and I'm sure that there is so much more that you could share with us, but unfortunately, due to time, we can't do that today. And for our listeners, we would like for you to join us next week when we discuss navigating the cold and flu season amid the COVID-19 pandemic. Have a good weekend, everyone. Be safe, wear your mask, wash your hands often. Make sure you wash that mask if it's a cloth mask. Hang it up to dry, and don't leave your home without it. Thank you again, and we appreciate everything that you were willing to discuss with us today.
Thank you so much. I'm happy to come back.
Thank you.